video to play. Okay, here we go. Alrighty, hopefully everybody was able to view that video. That's it for me. I am now going to pass it off to Rick.
Thanks, Adam. And just clicking on the slides here. Give me a second. Oh, great. It only took hours and hours of training to help me figure out how to advance a slide. So this is Rick Shuffler and Mike Fox and Patrick Canary from the Center for Innovative Practices at the Begun Center at Case Western Reserve University. We'll be moderating the rest of the webinar and just have we'll begin with the first couple of introduction and overview. Joining us today on our webinar, we are honored to have Bernie Centio from MST Services, who will be talking about MST and their new enhancement to MST in terms of contingency management, as well as Dr. Howard Little from the University of Miami, the developer of MDFT. So we're very excited about today. The goal today is really just to present an overview of effective substance abuse treatments that can be implemented within system of care communities. One of the take-home points is that substance abuse treatment works. There are numerous evidence-based and promising treatment approaches that have demonstrated effectiveness in reducing substance abuse in adolescents. And a couple of things we wanted you to know from having implemented both being in part of a system of care community myself, but also implementing substance abuse interventions with those youth, is that mental health providers are already working with youth with co-occurring substance abuse behavior and disorders. So they're already in your treatment room. The other take-home point is that mental health providers can enhance or adapt their services to include substance abuse treatment approaches, certainly with the appropriate training, licensure, and supervision, of course. Many of the interventions that address the needs of youth with co-occurring disorders are already in your toolkit and can be translated for use with substance abuse. For example, many folks are trained in motivational interviewing, trauma-informed approaches, cognitive behavioral treatment approaches, family therapy approaches, and risk and protective factor kind of approaches as well. So what we're saying is that many of the things we use with kids to help treat kids with substance abuse disorders, those are already in your toolkit. The challenge really is to use these skill sets more intentionally and to integrate treatment across complex needs of the youth and the family. The other thing that we have found over the years is that high fidelity wraparound is actually a nice fit to youth with co-occurring substance abuse disorders, because what we know about substance abuse disorders is that it's a chronic relapsing disorder and that they have long-term ongoing support and treatment needs. High-fidelity wraparound is a great fit to helping mine some of those support and treatments that these youth need ongoing. Okay, we are now going to go to the NIDA principles on substance abuse treatment, and for that we're going to give it to Mike Fox.
Good afternoon, everybody. As Rick mentioned, we're going to cover the principles of adolescent substance use put forth by NIDA. We're going to cover these pretty quickly. There's 13 principles, and this is for the implementation and the effectiveness of substance use treatment. We're going to cover them quickly because you can review those yourselves, and I would recommend to everybody listening who has any interest in this at all, downloading this NIDA publication from January 2014. It's really useful. We are going to present them quickly in terms of an integrated treatment approach, and that from a mental health perspective, how to integrate substance use into a mental health perspective. So that's how we're going to talk about it today. The first of there are 13 principles. I think it would have been a little bit more entertaining had they come up with 12 principles, and we could talk about the 12-step method of implementing substance use treatment into mental health, but we'll do 13. The first of those 13 is adolescent substance use needs to be identified and addressed as soon as possible. And it is really easy to miss when working with adolescents. And for those of you working with adolescents in the mental health field, I'm sure know from experience that it's easy to feel like you're getting stuck, like progress is not being made where it should. And very often we know that this can be, there's a little bit more going on that we're aware of. And we know statistically that there is a greater than 50% chance when you're working with an adolescent that if they have one side of the disorder, either the mental health or the substance use, that other side is also present to some degree. So the sooner we get things identified and kicked off, the better. The second principle to cover is adolescents can benefit from a drug abuse intervention even if they are not addicted to a drug. And with adolescents, addiction is kind of a loaded term. And for those of you that do any kind of diagnostic work with adolescents and in substance use, you know that their use looks a little bit different than it does in adults, or it looks a lot different than it does in adults. And how do we differentiate between abuse and dependence? They use in a lot more concentrated and kind of streaky methods. If it's available, they'll use it, and they will binge on it, and then they can go quite a while without using it, and they don't show the same withdrawal characteristics as adults. So it's tough to differentiate between those two, and and that's in the DSM-4. And as we move into the 5, we're going to have to differentiate between mild, moderate, and severe. So does it matter which end that they're on? It does not. If there is any kind of drug use going on, then we're going to consider that a co-occurring disorder, and we're going to integrate treatment from there. Number 3, routine annual medical visits are an opportunity to ask adolescents about their drug use. Most of us are clinical providers and not MDs, but this just speaks to the importance of any door that they come in should be the right door to be identified for all issues, not just substance use, but mental health, health screening, and whatever. So. Number 4, legal interventions and sanctions or family pressure may, as opposed to say play, unfortunately that was my typing, may play an important role in getting adolescents to enter, stay in, or complete treatment. And under that there it says research shows that treatment can be effective, and for us, certainly to help reduce risks, even when treatment is mandated, with a little comment added there, how often do teens come voluntarily? And we talk about that a lot, especially on the substance use side of things. Occasionally we will see adolescents who will talk about in treatment, I would like to feel less depressed, I would like to cut less, I would like to argue with my family less, but How often do they come to us as clinicians and say, I would like to smoke less marijuana. Please help me cut down on my weed use. That does not happen too often. It is up to us to help them find some of the motivation to move in that direction. So when there are these extra layers of external, let's say, pressure, that can clinically be very useful. Fifth, substance use disorder treatment, and really all treatment, and I'm guilty of saying especially co-occurring and especially for adolescents, but I think that that's appropriate here, especially thinking in terms of co-occurring treatment, should be tailored to the unique needs of the adolescent. This emphasizes the importance of regular and complete screenings leading to an in-depth assessment. And again, from a mental health perspective, if we are working with adolescents and we are just really stuck, things are not progressing, we have used all of our good clinical tools, and there's just no apparent reason for being stuck, that is a really good time to screen for substance use. Increasing our knowledge about what's going on in the adolescent's life by building collateral information. It is nice to have that extra layer of information. Ecosystemic mapping is something that is really helpful. Rick's going to talk about that here shortly as he talks about the ICT model specifically. So you'll see a little bit more about ecosystemic mapping and how that helps build information. Number 6, treatment should address the needs of the whole person rather than just focusing on the drug use or the mental health or the co-occurring disorders. I don't know if a lot else needs to be said about that. In terms of adolescence, we're not going to focus on one single area as we take a broader perspective. And again, that's going to tie into taking a look at that ecosystemic mapping. The 7th point, behavioral therapies are effective in addressing adolescent drug use. So things that we already know, things that we are already doing can be effectively applied to substance use treatment. A big one is strengthening motivation to change, and certainly that is both on the mental health and on the substance use side. Providing incentives for abstinence and other behaviors. So this is not just on the substance use side, working with families and increasing those incentives. Building skills, resistance skills, identification of cravings and triggers. And again, well, not again, but initially, we're not going to dive right into working on cravings and triggers until we can strengthen some motivation to change. That's getting a little bit ahead of ourselves sometimes. And we do know that the more positive behaviors that are going on in a youth's life, the greater the chances of moving towards abstinence and sustaining abstinence. Increase constructive activities and behaviors, the same thing that I just said. Problem-solving skills, certainly. Building hope and building the ability to problem solve, and better interpersonal relationships. We know, one of the big risk factors that maintain kids in their use is their peer association. So as we can improve interpersonal relationships both with the family and certainly with peer relationships, then we can hopefully help them move towards abstinence. The 8th point, families in the community are important aspects of treatment. This has kind of been woven into what we've been talking about so far. With co-occurring treatment, family involvement is vital, and a lot of families have fallen into patterns that are just ineffective. Increasing community involvement and buy-in increases the layers of support. So if there is probation involved, if we can keep them in the loop on that, certainly partnering with the schools quite a bit, and anybody else in the community that would be important. So expanding those layers out. And again, that gets into some of that ecosystemic stuff that Rick will be talking about here pretty shortly. The 9th point, effectively treating substance use disorders in adolescents requires also identifying and treating any mental health conditions that they may have. The not rocket science statement of the day. We're taking this from a mental health standpoint as it is. So if we identify and we treat both sides of things, both the mental health side and the substance use side is equally important. Certainly that is the direction that is going to lead to the greatest success. And if we can tie psychiatric treatment into that and make the clinical involvement part of that psychiatric involvement, that's going to increase the odds of success as well. The 10th, sensitive issues such as violence and child abuse or risk of suicide should be identified and addressed. Certainly, when we are doing mental health treatment, these are things that that we have to address quite often, and they are sensitive issues, especially in working with teenagers. When when we're the clinician involved, they can be sensitive issues for us to ask about these things and to probe for these things, and sometimes they require us to do some things that are uncomfortable. But these are things that certainly we cannot leave off the page. These are vital. So risk assessment and safety planning, co-occurring youth are very high risk. And just mention there's 67% of youth in CSAT-funded programs, so that means that they're there for substance use, reported experiencing victimization during their lifetime. So we should expect that all adolescents that we are working with, if they are coming to us for mental health issues, we should expect statistically that there is substance use going on. Doesn't mean that there has to be. We should just expect the likelihood of that. We should also then expect that there could be some victimization. So it's not guaranteed, but it's things that we should look for just because we know they are so prevalent. 11th, it is important to monitor drug use during treatment. Parents can be coached in this. So my hope for all of you is that you do not have to conduct drug screens yourselves. The very best drug screens are the urine drug screens, and really nobody wants to do that, but they are very effective. Parents can be coached in this. I think parents should be coached in this. You can go on the internet and you can buy urine screens in bulk, and they are far cheaper than they are buying them one at a time in drugstores. It's very effective. It's something that parents can take charge of, and certainly they should as parents. So just in quotes there to mention, and this is coming from that NIDA publication, a relapse signals the need for more treatment or a need to adjust the individual's current treatment plan. Put that in quotes there because very often that is the standard thinking, but we know that working with these adolescents, they're not going to consider use a relapse. It is just use, because until you're ready to change, it doesn't count as relapse. And these kids use. So sometimes if we find that they have been using, that is not necessarily a need to, in knee-jerk fashion, increase their level of need or increase their level of treatment. So. 12th, almost to the end of these, staying in treatment for an adequate period of time and continuity of care afterward are important. And this can be tough because if we are doing integrated treatment, and let's say that we're doing integrated treatment at a fairly intensive level, how are we going to step these kids down? Because how many communities have good step downs for co-occurring adolescents? It's tough to find. We are moving in that direction, but we don't have a high availability of integrated treatment programs for adolescents. So that step down can be tough to find. So the more we know our communities and the more that we help build these programs and the knowledge about them, the better off our kids are going to be. And the last one then, testing adolescents for STDs like HIV, as well as hepatitis B and C, is an important part of drug treatment. When we're working with co-occurring adolescents, we know that it really increases the odds that they're going to be engaging in high-risk behaviors. Unfortunately, and we're seeing an increase in this, it's somewhat regional, but a lot of regions, unfortunately, are seeing the increase in the IV drug use among adolescents. They are starting way before they should. So not that you ever should, but I think you all know what I mean. So, all right, you know what? With that one, you are, very luckily for you, done with me. I'm going to pass it back to Rick, and here he is.
Thanks, Mike. Continuing with the NIDA recommendations, we had some additional slides that we wanted to kind of complement the 13 principles. Certainly, all care needs to be culturally competent care. And what NIDA recommends is that programs need to consider the influence of stigma, discrimination, acculturation, language in particular, and the paucity of community resources. The reality is that the research is showing that treatment works across race, ethnic, race and ethnicity, but there's treatment disparities in the access to get to those treatments for those minorities, especially around the specialty treatments. And so we have to really pay attention if you're building up a set of services in your community. The question really is, how available is it to the entire community? For our LGBTQ community, treatment providers also need to be cognizant that the odds of substance abuse for this population was significantly higher, 190% higher than for heterosexual youth, and even higher for bisexual youth. And further, that for LGBT youth, they're twice as likely to attempt suicide compared to their heterosexual peers, and I've seen data that goes as high as 4 times as likely. So these are things also you need to be aware of when you're assessing and treating youth. In terms of gender, NIDA also talks about treatment needs need to accommodate the higher rates of internalizing disorders and trauma with adolescent girls, and higher rates of externalizing disorders and juvenile justice involvement with adolescent boys. So being very specific about your treatment. So providers should consider adding treatment components, for example, with adolescent girls that focus on trauma, personal safety, emotional regulation, and positive relationships. NIDA talks about 4 categories of effective practice. So when you go to the website, if you want to pull down the PDF, you'll see there are 4 categories, and there's many promising and evidence-based practices. We use their categories, so there are actually more than what we'll be talking about today. In terms of behavior and cognitive treatments, the ones listed are adolescent community reinforcement approach, ACRA, contingency management, cognitive behavior therapy, MET or motivational enhancement therapy, 12-step facilitation therapy, and seeking safety. We're going to talk about a couple of these, starting with ACRA. And if you want more information on ACRA, one of the best places to go is the GAIN Center at chestnut.org, listed at the very bottom bullet there. And actually, CSAT paid for folks to actually develop manuals on some of these evidence-based practices back in the day, and many of these can be found at chestnut.org, the treatment manuals themselves. And ACRA is one of them. The ACRA approach is a very behavioral approach to substance abuse treatment, and they can serve kids from 12 to 24. It seeks to increase the family, social, and educational reinforcers that support recovery. It can be implemented flexibly across environments, whether it's outpatient, intensive outpatient, and residential treatment centers. It focuses on a functional analysis of substance abuse and pro-social behavior. The treatment components include skill training in problem solving, effective communication, and pro-social skills. And it emphasizes developing pro-social behaviors to replace activities related to substance abuse. So the ACRA approach has gotten a lot of research lately, and again, if you want to know more about that, go to the GAIN Center at chestnut.org. Certainly, most of us are familiar with the cognitive behavioral approaches to mental health treatment, but also CBT can be used to treat youth with substance abuse as well. And the focus is more on monitoring feelings and thoughts and recognizing distorted thinking patterns as it relates to triggers to substance abuse. Works with youth to identify and anticipate high-risk situations and apply an array of self-control skills, emotional regulation, anger management, problem solving, and substance refusal. Like ACRA, CBT it can be used very flexibly across settings, whether it's outpatient, residential, intensive outpatient groups. Many of you have been trained in MI, motivational interviewing, certainly in many of your system of care communities. But also, this has become like a very key approach in substance abuse treatment. And MI is a collaborative, goal-oriented style of communication with particular attention to the language of change, designed to strengthen personal motivation and commitment to a specific goal by eliciting and exploring the person's own reasons for change. And it addresses common problems of ambivalence and change. Important developmental consideration is that motivation to change may be, as Mike said earlier, much lower for youth as they've experienced fewer consequences from drug and alcohol use and are often mandated into treatment. There's also group therapy considerations for adolescents, and the literature is kind of mixed on this. However, where it is, the most recent research has said basically that when led by well-trained clinicians following a well-validated CBT protocol, groups can provide positive social reinforcement through peer discussion and help reinforce incentives to stay off drugs. But there are some unintended adverse effects, which is the other side of the research. Group members glorifying drug use, making new negative connections, etc. But it is in the NIDA print handouts. In terms of addictions medicine, I will just basically say that we are very well aware of many of our communities that opiate use is on the rise, as well as the unintentional deaths associated with their use, and that kind of most recently in the last 5 to 10 years, there has been an uptick in psychiatrists and doctors using medication-assisted therapy, especially around opioid use, and you might have heard of Suboxone before. And there have been some trials that basically have found that it has worked well with youth as well as adults. The last two categories, one is recovery support services. As we said, substance abuse is a chronic relapsing condition, so that we need to have ongoing supports and treatments to help youth in their sobriety. The ones listed in NIDA's PDF are assertive continuing care, mutual help groups, peer recovery support services, recovery high schools. And again, what's not mentioned, but what I do want to mention myself is high fidelity wraparound is actually an excellent vehicle for planning and supports for recovery ongoing. In terms of 12-step groups, what I want to mention is that there's some decent research that basically says for youth that do go, they seem to have better abstinence levels over time. But what we have found in our implementing our substance abuse programs is that you have to be very careful in which 12-step group the kid goes to. Adolescent-specific groups are better, where they are supported possibly also by an adult recovery mentor. The pros, and this is from John Kelly's work out of Harvard, are that 12-step programs can be cost-effective, they're widely available, and certainly a long-term resource. The caveats is be careful of the potential mismatches, as we said earlier, with the age composition, mostly adults, but also the developmental readiness of the youth to grasp the higher level concepts. So they're in a 12-step program. And keeping in mind that if it's an adult-only group, that the substance abuse severity and chronicity is much higher, and that would be a mismatch for our kids. And I'm just going to mention again that high-fidelity RAP is a great planning process for the ongoing needs of our kids. And what we're going to talk about now for the last hour is family-based treatments. One of the reasons we chose to focus on family-based treatments is the research is showing that family-based treatments in particular actually have a greater comparative treatment effect for youth with substance abuse disorders. So while all these programs that I've mentioned so far have shown a significant positive effect, the family therapy treatments seem to even do a little bit better. The ones listed in NIDA are brief strategic family therapy, family behavior therapy, family support network, functional family therapy, and today we're going to actually focus on multidimensional family therapy and multisystemic therapy, and we'll get to those here in a minute. But before I do that, what I wanted to talk about was integrated treatment approaches that actually were developed to serve co-occurring kids specifically. One of them was family integrated transitions, and this is out of the state of Washington. Eric Truppin and his group out of the University of Washington developed a program that really focuses on juvenile offenders with co-occurring disorders. And they combine multisystemic therapy, dialectical behavior treatment, DBT, and MET. into their program, plus a parenting skills training module. And there's, they consider it to be a promising practice because they're still doing research. And I'm going to talk to you in the next 5 minutes about integrated co-occurring treatment, which is a model we developed in Ohio. And ICT is an integrated model designed specifically for youth with co-occurring mental health and substance abuse. And we focus on high psychiatric acuity youth with significant substance abuse problems. We utilize an intensive home-based treatment approach to deliver a comprehensive set of individual and family-focused mental health and substance abuse interventions to impact the kids' functioning. And we're going to show you what that looks like here. And this is the ICT model itself. So again, we use an intensive home-based service delivery model. We grew this actually out of our experience in a system of care community. And so it embraces system of care principles, including culturally mindful engagement and family partnerships, and taking a resiliency-oriented developmental perspective approach to working with youth. In addition, we really emphasize the cross-system collaboration, community teaming to affect change in these youth. It's not uncommon for us to meet regularly, weekly or every other weekly with probation staff or court staff or school staff, much like what you're going to hear with MST and MDFT, so that we can team effectively to help the youth be successful. In our model, we also use an integrated contextual assessment and conceptualization approach to figuring out what the problems to be solved are, and then use a comprehensive and integrated treatment approach matched to the needs and strengths of the youth and the family. We put this slide in just to show you the interaction and impact of multiple individual and contextual developmental factors. The reality is these kids are complex. And we really focus a lot on conceptualization, trying to figure it out. If you're working with mental health and substance abuse and trauma and other risk factors, as well as family issues that are going on, it really challenges us all as clinicians to not only to figure it out, but also how do we help them be successful. These are the things that we have found over the years that we need to make sure go into the conceptualization: trauma, risk factors, protective factors, developmental factors, all the contextual pieces and parts, including home, school, peers, community. You can see at the bottom here also in red is safety concerns because, again, as Mike said earlier, these kids are high-risk youth with numerous safety issues. And so we have to put this all together and see how it interacts and then find out what we need to do. I'm not going to go in detail over the slide, but basically intensive home-based service delivery model basically are small caseloads, intensive services, and fairly short-term, 3 to 6 months. We're trying to prevent placements and start youth on the road to recovery. We don't necessarily believe that all of the kids will get into total recovery because the research just doesn't show that for any of the models. Mike mentioned earlier our ecosystemic mapping. This is one of the tools that we use in the ICT model to look at what are the risk and protective factors in each of the life domains that affect the youth. How well are they doing at school? How well are they doing with peers, family, et cetera? And it's really a shorthand method to bring into supervision or into case consultation to start talking about a case to make sure we're not missing large pieces of information. We also use we stole from Maslow, you know, and we created our own youth and family need hierarchy. And because the reality is if you're working in a family's home with high-risk situations, there is so much to be done, you have to prioritize the work. And it's impossible to do it all right away. And so we developed a hierarchy of where do we begin to help especially novice clinicians figure out where the starting points are. Obviously, you know, are there any basic needs and safety that need to be stabilized for the youth to be successful? Do they have the developmental skill sets to do what we're asking them to do, or do we need to start to teach things? This would include psychoeducation. How well are they doing in each of the environments we're asking them to function in, including school, home, and community, and working through that, and then ultimately wellness recovery. The key buckets, if you will, buckets of treatment, For us, as a little bit repetitive here, are safety, stabilization, risk and trauma, symptom reduction. This is where we always begin. It's really hard to start on higher level interventions when the family's not safe, the youth's not safe, the kid's not stable. So we always begin with stabilization and safety issues, including creating trauma-free environments. We like to say that ICT, as well as intensive home-based treatments in general, are frontline trauma services because we create safety in families' homes. Another treatment bucket that we look at is engagement and readiness to change. As Mike said earlier, it's a key aspect of getting kids in treatment, keeping kids in treatment, keeping families in treatment. So we work heavily on that. Building adaptive skill sets, emotional coping across settings, and a strong psychoeducation component for our kids with substance abuse issues. Establishing positive connections and functional success through relational supports and strategic accommodations. You know, we can build up a lot of skill sets, but sometimes there's a ceiling to a kid's capacity to do what we're asking them to do. So in a school setting, for example, are strategic accommodations needed for them to be successful, and what do those look like? And then how do we translate what we've learned about the youth from a mental health and substance abuse our assessment to those other settings? Certainly working a lot with the families, as you're going to also hear from the other models, solidifying family structure, relationships, supervision and monitoring. These are critical factors in helping our kids be successful in both in recovery and resiliency. And then ultimately, at the end, our kids have to have a strong set of protective factors in their lives. And the research is really clear on pro-social recovery that you need to have, pro-social activities, pro-social kids in your life, peers, pro-social assets, and supports. One of the concepts that we like to put forward a lot is, instead of thinking about always 12-step groups, be thinking about recovery mentors, if you will. And how do we identify those recovery mentors that are positive and those supports for a kid in their life? And that's one of the reasons I like using high-fidelity wraparound, because it helps identify those folks. And I think that's it. So that's the integrated co-occurring treatment model. And at this time, we are going to head and pass this on to Bernie Centio from MST Services, Inc. Bernie.
Well, thanks, Rick. Actually, I'm getting ahead of myself with slides. Thanks for making time today to include MST in this discussion. I'm excited to be here. And I think folks in general may have an idea what multisystemic therapy is, and I will cover a little bit of that today. At MST Services, I guess in the world of implementation science, we are considered a purveyor organization. So we provide technical assistance, training, clinical consultation, and program development support so that more families can benefit from MST across the world. I think right now we have about 550 MST teams operating at various places in the world, and we have great community partners through the Center for Innovative Practices and Case Western, through the University of Maryland and the Innovations Institute. So we've really developed strong collaboration with folks on the ground who are doing their own training and support so that we get good outcomes for families using MST as the vehicle for that. I just wanted to talk a little bit about what MST is. I think you'll find that across these slides I'll be repeating some of what Rick said, and next time I'll ask to go first so I don't have to be in the position of repeating what someone else has said. But MST is a community-based, family-driven treatment working on the key correlates of adolescent antisocial behavior. We really put a strong focus on empowering caregivers so that parents can solve the problems that are happening in their family now and in the future. And we include families fully in collaboration and treatment planning with the focus on the family as long-term change agents. So though they may need step-down services after MST, what we're always trying to achieve is sustainability and generalizability of treatment gains during MST. In MST, the client, in our view, is really the entire ecology that the youth is nested within, so family, peers, school, neighborhood, and all of the various components within each of those ecologies. And then one of the hallmarks of any evidence-based program, and I think the reason that we fit well within systems of care, is that we typically, and in MST this is the case, use highly structured clinical supervision and quality assurance processes. So we're really working hard not to just do the old model of train and hope, but instead stay with the program so that we can better assure positive outcomes for families and for the kids that we're treating. I'll talk a little bit about who we serve in MST. Our inclusionary criteria is for youth at risk of out-of-home placement. This is usually due to antisocial or delinquent behaviors, and that includes substance abuse. So it's one of the typical referral behaviors for an MST kid. Our youth are generally involved with the juvenile justice system, though in some cases the actual referral system is children's mental health or occasionally child welfare. And it really, that is really just dependent on how the system is set up. We do treat youth who have committed sexual offenses in conjunction with other antisocial behavior, and you'll see in our exclusionary criteria that if sex offending is the only behavior that the youth is being referred for, that wouldn't fit with MST. Because we're family-based treatment, we're not working with kids who are living independently. MST is not well suited to treating youth with moderate to severe autism, nor are we well suited to treating kids that are actively homicidal or suicidal or psychotic, though we certainly have youth on our caseloads who have threatened suicide or made past attempts, but at the time that they're referred, those behaviors and those intentions shouldn't be active for MST to be effective. And though we have youth who present with many symptoms, and as you know from kids on your caseload, by the time they reach the juvenile justice system and are kind of what we call deep-end kids, they may have multiple diagnoses coming in. We aren't well suited for treating youth that are presenting primarily with problem sexual behaviors or for psychosis. But we definitely have youth on our caseloads who are presenting with a variety of other psychiatric problems. As you saw with ICT, MST is a home-based treatment model. We have small caseloads and small teams so that supervision and consultation can be most effective, and therapists get a lot of feedback about the direction of treatment in a given week. We're on call to families 24/7, and the typical treatment time, as with ICT, is relatively short. 3 to 5 months is typical, and that's really related to our the effectiveness and efficacy trials that were done on MST, where after 5 months, treatment gains weren't really notable and kids kind of plateaued. And so we have kind of a strong commitment in MST to continue to do what we know is effective, and we're very, very cautious about branching into areas where we're not quite sure. And so we know that after a certain period of time, around 5 or 6 months, it's less likely that MST, which is relatively costly, won't get the same outcomes after a while. So we'll usually discharge kids, but we work really hard to get treatment gains within that time frame. And we are working in the community and home, primarily doing family therapy in the home, but also joining with caregivers in the school, helping them look for their kids in the community, and sometimes developing social supports for caregivers and youth in their communities so that they are better able and better equipped to do the things that we are discovering with them will help keep their kids out of trouble. So whether that's finding the coach of the community basketball league or relying on extended family members for monitoring. We're doing what we can to help caregivers mend bridges, find resources, sometimes helping with those things monetarily to kickstart things and ameliorating those risks that exist for families. This graphic we've used for a long time in MST that sort of shows some of the causal modeling for delinquency and substance-using behavior. So I think, folks on this call are familiar with the fact that youth who get in trouble with the law, that they often have substance abuse problems. And I think of about 1.5 million teens that are arrested every year. About 300,000 of those arrests are for drug and alcohol-related crimes. I think we see the same picture in Europe and some other international settings. And so what we know then is that the successful treatment of adolescent antisocial behavior and the effective treatment of drug and alcohol use go kind of hand in hand. And so the highlighted square there around delinquent and substance-using peers is really highlighting the highest risk factor for substance-using behavior and for delinquency in teens. So we put a lot of focus through the family and through helping find the youth the appropriate school setting to change the peer ecology. There's not a lot clinically that can be done about prior delinquency and prior substance-using behavior, but we do try to account for those things and understand functionally what occurred so that we can get in front of them occurring again. And so I like this causal modeling also because I'm noticing that my graphic doesn't show arrows, but what it should show is arrows going from the school to the peers, from the family to the peers. I think you can see from peers to current behavior. And one of the things that I love about working in home-based treatment is that you're working on understanding those pathways and how the family interactions interfere with the youth hanging around positive peers, how the family interactions lead the youth to leaving the house and going to get high. And so we're really focusing on those interactions and pathways pretty significantly in MST, how the youth school attendance and participation has been interrupted. And when we put kids in residential treatment, which has been unfortunately the long-held standard, all of those arrows disappear for the time that the youth is in treatment, and then when we put them back into their community setting, all those arrows reappear, and usually not much has been done to be able to address those things. So I appreciate the focus on family-based treatments. I think we do kind of win the prize for getting good outcomes for kids. And I think that probably ICT and multidimensional family treatment would also build off of this 50-plus years, probably 70-plus years of research by this point in time to identify risks and even protective factors. And from that causal modeling, we then have developed an MST theory of change, or a little bit of our kind of a condensation of our logic model. Again, working through the family to, in treatment planning, address how the youth engages with peers, how we get the youth more functional in school, addressing community risks where we can to reduce youth access to drugs, weapons, negative settings, and through that functioning we get improved functioning for the youth and reductions in antisocial behavior, including substance use. And so MST, I think, is familiar to a lot of people because it has become, through the hard work of folks like Patrick Canary and others, preferred treatment for adolescent antisocial behavior. What I think is less widely known is that MST is also in the top tier of research-based interventions for reducing and eliminating substance abuse among teens, and it's through this same theory of change that we achieve those outcomes, again, because the causal modeling is similar for substance use and criminal behavior in adolescents. I'll go into a little bit of the research behind MST as a substance abuse treatment. We are considered efficacious, effective treatment for substance abuse through a couple of randomized trials. And I think this kind of builds off of what Rick was saying, both in terms of NIDA principles and some of what they're focusing on in ICT, that there's a really strong emphasis on engagement and retention in treatment. And so in the clinical trials, we had about 98% treatment completion, which is a great retention rate. And as you know from working in substance abusing, in the substance abuse field and with substance abusing kids and adults, it's often very difficult to achieve treatment completion. In the real world, our outcomes for retention are a little bit lower. I think in our 2013 data report, we had about 85% retention, which is still really great. So we pay attention to that in MST and work to solve problems when we're not able to keep folks in treatment, knowing that we'll get much more sustainable outcomes the longer families can keep learning with us and teaching us about what helps them. In terms of substance use, we got greater post-treatment reductions for MST and increases in regular classroom attendance. And I think that regular classroom attendance is kind of critical, since we know that the life-term trajectory for kids is much better when they are able to be engaged in traditional standard education classrooms when possible. Their longer-term trajectory isn't as positive when they've been in alternative settings with other negative peers, or where teaching becomes very difficult, both for the teacher and for the student to learn. So we do have a strong focus on that, on school attendance, to gain better outcomes for substance use. And I think I'll leave these mainly for you all to look at on your own, and shift a little bit to what we're doing in MST through contingency management. CM is based on the community reinforcement approach that Rick described earlier. It's one of the most extensively researched and best validated interventions for substance abuse treatment, and has promising results when it's been used in MST treating adolescents. So we've used it in juvenile drug court, getting better outcomes, and in particular when contingency management is imported into MST and used whole cloth, we've gotten accelerated decreases in substance use. So kids that are in MST are already getting reductions in substance use, but that uptake happens more quickly when CM is included. And 12 months post-treatment, we had 60 to 74% reductions in self-reported use, and that was for alcohol and marijuana use. I think there were some polydrug users in those settings. And so a little bit more about CM, which maps really well onto that theory of change in MST. CM uses ABC assessments, or functional assessments, to understand patterns of use and to understand non-use. Family drug management planning is kind of a problem-solving process that we engage caregivers and kids in, and we teach drug refusal skills and avoidance of risky situations. I think what's important here is that throughout CM and MST, caregivers are highly involved, and again, that's towards sustainability. So you won't often see an MST therapist working solely with a youth doing an ABC assessment or working on a drug management plan, but instead those interventions would happen with the caregiver. And as you might expect, there might be some focus and emphasis working with the caregiver individually or caregiving team separately from the youth to prepare them for being effective at teaching their children drug refusal skills. So we work really collaboratively to understand how, when, where, and why the youth is using and what we need to do to interrupt those opportunities. CM uses a very structured point and level reward system with a checkbook and register for kids. So that really is similar to other behavioral interventions that you all are probably familiar with. There's just a very clear protocol in CM for helping families to use this effectively. And of course, they must use drug testing, which you'll recall is one of the principles that NIDA touts as being important to getting good outcomes. And as I think it was Rick said, it might have been Mike, but they were talking about drug testing happening through caregivers. And so by helping caregivers drug test kids, we're helping them to develop strategies for doing this over the long haul, helping to reduce conflict because they are able to get more objective results and not have to get into a tussle about whether the youth did or didn't have glassy eyes, did or didn't smell like alcohol. And it's also a great way to test whether treatment is working. And so we can test other interventions by the outcome of the drug screen. And so if a kid drops a hot screen, then maybe we have to work a little bit harder on monitoring or maybe work a little more effectively on drug refusal skills. And we do our typical MST fit assessment alongside all of these interventions when we use CM and MST in order to understand proximal factors and drivers related to problems. I will say that in MST, of course, we are working on a number of issues at the same time. So while we are helping caregivers work with a focus on substance abuse outcomes, we're also working on managing truancy, curfew violations. Probably with a lot of our kids, there have been aggressive incidents in the family. So we have a strong focus on safety first, similar to what we heard about ICT, that we need a bit of stability and certainly we need safety before we can jump into any other treatment in any intensive way. So these things are happening alongside other interventions while CM is being implemented in MST. And then here's just a little bit about some more about the compatibility, addressing key risk factors across multiple systems. And I think within MST, we are still focused on quality assurance and attention to fidelity. So therapist adherence to MST principles is still measured. We learned through our original research that substance use outcomes were impacted by treatment fidelity. So where therapists didn't adhere to treatment principles, substance abuse outcomes weren't as robust. So as we do for other interventions and outcomes in MST, we're really focusing on that quality assurance component and working toward measurable outcomes. So helping families toward the end of CM within MST to create sustainability and sobriety plans for their youth, thinking about, for example, how often they might do drug testing, where they might procure drug tests. We'll probably leave them a few, but they need that resource moving forward in most cases, how they'll sustain other monitoring interventions, and work with them to achieve outcomes that will last over time. In terms of contingency management within MST, we've had just a little over 10 years of real-world implementation, much of that in New York City. We have MST SA adaptations occurring in Denmark, Denver, and a couple of other isolated sites, I think a couple in the UK. Throughout that time, Elisa Rowland, Scott Hengler, Philippe Cunningham, and others were developing a CM treatment manual and some standardized training. So that treatment manual is available to all practitioners, and it's not intentionally created for use within MST, but all of the skills and principles captured in the manual are applied within MST. So through all of that real-world experience and the development of some more standardized training that can be imported to MST, next year, instead of just having teams be able to pick and choose from CM interventions that they'd like to use, we're going to be integrating the technology more fully across all MST teams. So for any that are interested, they'll be able to get CM training. That'll just help to upskill clinicians a little bit and get them more familiar with some of the parts and pieces in CM so that they'll be able to use those more fully across their treatment, across their caseloads. And I think that kind of wraps it for me. I did leave you with some of the support for MST as substance abuse treatment in case you're interested in looking that up. And I think at this point I will hand it over to Howard Little from Multidimensional Family Therapy, just in time because I've lost my voice. Thanks, everyone.
Okay. Getting set up here. Okay. Good afternoon, everybody. How's it going out there? I'm getting feedback on my monitor. Hesitating. Andrea, are you getting this echo?
Yes, we are. If you could just mute your computer speakers, that should get rid of the echo.
How's that? Better?
Sounds good. Yep. You're good
Is
to
that
go.
better now? Yeah?
Yes, sir.
Okay. So what I'm going to try and do is really address the question that's in the first part of the title of this presentation. You see it right there. It's really just those two words. How? Really, but how? We think about what we've been talking about so far and really think about what's happened in the field as we discovered a few decades ago co-occurring comorbid conditions. I've written about it, researched it from a developmental psychopathology point of view, from a developmental epidemiology point of view. We know a lot about how the problems develop, how they interact. We know about the long-term course. But if you think about what's happened in that big puzzle, the piece that's still to be sketched out fully has to do with, okay, now that we know all of these things, what really is the treatment? What does it really look like? And what I mean by what does it look like is not only in terms of the manuals that exist or the clinical papers that we've written, but what does it look like if you were in the room, if you were in the living room talking with the mom, or in school talking with the kid, or in court with both of them in a session just before. the hearing begins. So what do those conversations look like? So long story short, that's what I'm going to try and do. Even though the first part of the presentation deals with a few of these things, as I started to say, the topic that we're here to talk about, its importance, the increase in the knowledge about it, its place, its undeniable place in the current landscape across sectors of care, right? It's not a mental health issue, a substance abuse issue. By definition, it's cutting across the silos, the conceptual silos, the clinical silos, the research silos, the policy silos. So that's what's so exciting, I think, about all that is happening, that people realize what the problems are and in terms of what's needed. And there are, yes, many systems issues that get in the way of this kind of treatment, but thinking about what's happened in the last few years, the treatment research community, certainly across those sectors of care, across these empirically supported models, they understand what the target is anyway. And as we know in clinical work, if we know the target and we realize that affecting that target or targets affects a bottom line outcome, then we can move pretty fast and develop, let ourselves be creative and flesh out the ideas, whether those interventions are at a system level, a county level, an agency level, or at the level of a case or the cases that you see. As everybody knows, this stuff, this evidence-based thing, whatever it is, movement and research, clinical work, all this, it's been around for a long time. It was intended to not generic, these are not generic models. These are not one size, I got this approach, and well, it pretty much works with all of these problems. It doesn't work that way. So even though there's all this diversity of theory bases, from behavior therapy to family systems work to classic addiction treatment being integrated into empirically supported therapies, there's all of that diversity, but on the clinical side, it's of necessity. Those studies that are done, they're funded by certain by funders, federal or otherwise, that have a certain mandate and set of problems that they're trying to solve. So this idea of having broad-based treatments that attack, that solve in a collaborative way, more than one problem. As strange as that sounds, there's reasons why the treatments, at least from far away, were more narrow. In reality, some of these treatments were not so narrow. That from the beginning, we were all seeing comorbid cases. Now, whether or not the measures were there to have a variety of outcomes to report on, drug abuse outcomes, time disorder, diagnosis, behavioral problems outcomes, whether or not you had measures for all of those outcomes for all of these years is another matter. So you have to go back and look at these treatments one by one and see who did what in terms of being able to report different outcomes. But in a treatment development sense, this is not new for the treatment developers or the research people and the teams that have been doing this for many years. The summaries down here to this slide, to this bullet point, the summaries, the policies, the analyses, independent and otherwise, all of these things are widely available. I have the links, many of the links at the end of this, and Rick and Mike and company have some of those represented in their slides as well. So the information that's available is massive, available at the, as you'd say, at the it's in front of you right now. You could find many manuals, many state-of-the-art studies, many sets of recommendations. So that's not the problem, really, of finding the background about these treatments or the theory of them or the original studies or summaries of the studies or independent analysis of the studies. That's not the challenge right now. The challenge for most clinicians is to make sense of what these treatments are in a visual, in an experiential, in a, okay, you know, that sounds great, but how do you do it sense? And so that's what I'm trying to do here today by really having the center of what I'm going to do be the video. This MDFT work that we've been doing has been occurring for all of those years, that number of years that I mentioned. We started this in the mid-'80s. The first project began in 1985, so this isn't a new kid on the block by any means. And there's a dozen controlled trials, and it's about substance abuse, but it's about many things. And you'll see that, I think, in the video, the range of behaviors that we're interested in and the different means that we go about trying to uncover what's useful to talk about. The idea of what a clinical orientation is, just to say a couple of things about that, I think the key words are all contained in that first or maybe first and second bullet. That our therapists in MDFT, they think of themselves as experts on context, on multiple contexts, and they also think of themselves as experts on development. They're developmentalists in a sense. They're facilitators of positive youth, parent, family development. So yes, they take into account and they intervene in communities at the intersection of a kid and juvenile justice, or a parent and school, or a kid, let's say, in a work setting. So of course we are there at those corners, those intersections, but primarily I think most things run on a day-to-day basis in this kind of treatment through the self of the kid, changes in the individual development of the kid, individual development and functioning of mom or caregiver, parents in the house, maybe extended family as well, and certainly understanding how those pieces fit together in terms of a dynamic and evolving social context. So I think you'll see some examples of that in the video. But these problems of drug taking and mental health problems, many therapists, once they start tipping over into the realm of, wait, what are you saying now? I'm supposed to see, I'm supposed to be an expert in comorbidity as well. You know, what I want to do in this presentation is really center it all in the skills and in the focus of a clinician, and not go to diagnostic or assessment issues, as important as they are to organize a treatment. But I want to really telescope in and say, what are some core things, and can I show in a few minutes of the video some core things that an empirically supported treatment can get to and are connected to positive outcomes. So in that regard, in these segments, you're going to see three different distinct but connected areas of work. A few minutes of me and the mom, with me and the kid, and then us together. In MDFT, there's core sessions. You know, today's not the day to go into all of these things. I'm hoping some of these links may be of interest. You could see more videos. You can see manual type things. You can see the protocols in black and white. And I suppose after something like this, they may make more sense. But as I said, to me, it's all about seeing and trying to find a way to get practice in these things these days. A final thing to say in terms of the segments that you'll see is really the final few words on that fourth bullet. This idea of hoped for, the intentions or the hoped for processes. So it's easy to see therapist technique or even therapist style and to comment and ask questions about that. And that's one thing of interest and something that's valuable. In addition, however, you're always thinking this way of thinking anyway about hoped for or intended processes. You know, the technical term is mechanisms of action or processes of change. And I'll tell you, if there's one thing that we're always, the cutting edge, of the training is to help therapists become psychologically minded, to be family minded, to be social system minded about processes, about behaviors, the things that they can envision and the kid and the family can envision that are going to be helpful to me, helpful to us, and helpful to get us out of this mess that we're in. So, Rick, I'm going to stop it there. Can we roll it? Part one. There he is. And we're going to, Rick, we're going to stop. Yeah, there it is. Wait, though.
Okay. I'm going to start the video now. Just a reminder to all of the attendees that the audio from the video will only come through your computer speakers. Howard, as a reminder, if you could mute your phone and then unmute your speakers to listen to the video, that'd be great.
All right.
And we'll start the video now, and just let me know when you'd like me to pause.
I will. Okay. Adam?
Yes, sir.
Yeah. We're paused now, correct? Yeah.
That is correct, yes.
All righty, thanks. So I see time is marching on here. So folks can see that slide on the left now?
That's correct, yes.
Yeah. Okay, so the folks that are still with us here, I think you saw some of this. In the full video, you'll see really the progression, perhaps more dramatically. But this is a mom who entered with a full, I cannot take this. I will not take this from him. He just needs to go away. And why does that change? See, that's what I mean about a process mindedness, right, with a therapist. they have to think about what's going to change that. Telling somebody directly or exhorting them or lecturing them, that's not change. You know, I'm depressed. Okay, don't be so depressed. I can't go to sleep at night. I'll go to sleep earlier. But sometimes simple things work. Most of the time they don't, though. So change, why we're interested in therapy and these kind of things, we know that change is a little more complicated. So some of these other bullets from 2 on down, you see aspects. I think of what the process, what the intended processes were in that first segment, and they'll continue in the others, focusing on aspects that are available to the mom, but they're not really present. They're crowded out, sort of, at the moment. So you see processes, reflection, clarity, a fuller experience of her son's circumstances and indeed her own circumstances and the potential trajectory, the potential path, the consequences of the path that he's on. So even that word, you know, in the literature, paths, trajectories, these are words in an article, but when you see them in a session, it's something else. We are talking about, where is this guy's life going to go? Where do you think it's going to go? We're not just making this up. Those juvenile justice records are real. The expulsions from school are real. Getting beat up, having cops, all of those things are real. So those at the outset of the therapy, this is a therapist stock in trade. These are painful, terribly painful, horrible aspects of an individual, the family's life at present. Yet they are your allies. They are your best allies. We talk about what is motivation and why should someone think about changing. It's not just balance theory. It's not just a piece of paper. On the left-hand side, the pluses, on the right-hand side, the negatives. It's more complicated than that. Next, Adam, let's go to the segment, huh? Part 2. Okay. So a couple of short comments here. You see some alternation back and forth between topics. So things like using the drug screen, doing drug screens, and using the results of drug screens right in the session. That's a little more elaborate than I can put in a few minutes. But that kind of protocol, that outline of what exactly you do in a family systems context and an MDFT context, that's in the manual. There's a good section there on that, use of the drug screens. But in terms of what you do see here, I think you see a therapist oriented toward developmental things, milestones, areas of competence and problem solving regarding the specifics of his current situation, certainly the development of alternatives. And as I said there, without getting too far ahead of him, I'm trying to, you see like a tacking sort of back and forth between me and him. What I'm in my mind there is really highlighting and trying to accentuate the kid's idea, his idea about what might be possible to distance himself from that friend, and indeed, as we talked about it, others. And his method, there was a concrete thing that he discovered, this writing thing. It's just a simple journaling thing, but we used that significantly, and that worked beautifully for him. Okay, Adam, let's go to the final segment, and here it is. It's just a little few minutes from the family session in the middle of treatment. So I'm going to wrap up here. If we say what you could read so many articles and manuals, and you'll go to conferences and say, well, yeah, I ought to be doing a family-based treatment, a family-centered treatment, family-involved treatment. That's a common term. What does that mean? Do you have an image in your mind of what that means, of what you do to try and actualize those phrases? Those phrases connect to real life, real people, real behaviors on your part. So what you had here was a, under the hood, pick it up and show a piece of it. That's an aspect of this MDFT, this family-based, family-centered treatment. Attempt to change, quote, change relationships, to have a relationship focus. And you see many things that a therapist is trying to do here. You deal with the issue of what's the pace of a conversation? What should the focus be? How does something get elongated, made to sit on the table, not take it away, to let it sit and deepen a little bit longer? The enablement of certain kind of topics, support for certain kind of topics, the avoidance of others. I think those are the things you're seeing here. Those are mentioned on the slide here as well. This slide, we're back there. This is sort of a summary. It's maybe down at that bottom bullet. This idea of attempting to have an orientations that you hear about, that you've read about, and you hear the words. What does that look like, though, today, tomorrow, in a session that I'm going to do? Everything depends on you, not the manual. You can know the treatment, but you still may be doing things that are less than helpful. So the idea of the support network that must exist, the ongoing support and supervision that must exist within the evidence-based practice movement and systems, sure, but this is what I think we're all after, of changing clinical practice in a way as we know it. It takes the results of our work and indeed the results of our own training to be fully accountable for that in the deepest sense of that term. The reasons why we all came into this field in the beginning, we wanted to be helpful. We thought we had something to offer. We saw a career opportunity. We said, maybe I can do this kind of thing. I feel for those families, those situations. And so I think this final slide here gives you many options, and at least from our slice of the world, everything from the studies themselves to clinical articles and so on. The final thing I'll say is if you're not involving the family in treatment doesn't mean that you're working with the family, really. It doesn't mean that you have the needed goals to change and enable positive relationships to occur. Too many therapists, too many places are using a phrase like, yeah, I got the family involved. But they see the family every so often. They're not really making any attempts to enable, to change, to support the strength, the commitment, the love that is just beyond, is just outside the door. And there are things, relatively easy things that you can do if you have the skill and the courage and the willpower to get in and to make those things really materialize. That truly is the magic of therapy. And that may really sound strange for one of these evidence-based practice people to be talking about the magic of therapy. But believe me when I tell you, I still think in those terms as well. Because when you do sit in the room and these things happen, people start feeling and looking at each other and you, and it's not just in the room, it's what happens that night and the next day and how they talk to the school and the JPO differently and how their way of relating to each other is is profound, can be profound in the context of, as other clinicians will say, the severe mental health problems. These are juvenile offenders, and these are drug addicts. Well, those are points of view, and yes, they reflect serious impairments in multiple areas. But the way we all started out with in this field, I think, was looking for a way that came at difficult clinical situations and said, is that all? Isn't it more complex than that? Isn't there something that I can do, that my approach can do, to loosen this and to build bridges to a very different today and tomorrow? And the long and the short of evidence-based therapy is yes. All of these approaches, this is what they have discovered and what they're trying to tell the world about right now. I thank you very much for your attention and time.
Okay. All righty, just to finish up, I'm going to actually go right to our resource slides. I want to thank Howard, Dr. Little, for really coming and helping us with, as a developer for a model, we're honored to have him. And Bernie from MST Services, Inc., thank you so much. But what we've included at the very end of the PowerPoint is all kinds of resource websites for you, including promising and best practice substance abuse sites. We've also included our new briefs that the TA network has put out on substance abuse and co-occurring treatment and where to get them on the website. And there will be 3 more coming on treatment and implementation and outcomes. And we have references that we've included. And in the last slide is web resources that you could just click on and go to MDFT, MST. We put in functional family therapy here. The ACRA manual is actually at the very last one. And the NIDA Principles of Adolescent Use Disorder Treatment, a research-based guide, and that's the website you can go, or the HTTP that you can go to and get that as well. Thank you very much for attending. And next Tuesday at 2 o'clock, November 25th, we'll be holding office hour from 2 to 3 to answer any questions that you have. So that's next Tuesday, 2 o'clock, November 25th. We'll be holding office hours to answer any questions. Thank you very, very much for your time.
Thanks, Rick.